Hello, I'm Nick Stephenson, radiologist in Wagga, been there for 29 years. And I'm become an advocate for rurally based education and training, and particularly how it impacts on the medical workforce of Australia. And so tomorrow morning we're going to be having a session where we're trying to explore how we can increase the size of the radiologist training pipeline in rural Australia and New Zealand, so that we get more rural radiologists. Now, there's excellent observational evidence from around the world showing that if you train doctors rurally, they will choose to live and work rurally. So if we are going to correct the maldistribution that exists, and it's a very important maldistribution, I'll come to it, of radiologists in Australia and New Zealand, we need to do more rural training. So the census shows that about 33% of Australians live rurally, and that's been constant for about the last 30 years. But the numbers of radiologists living and working rurally has plummeted, and there's now a 4 times difference in the density of radiologists rural versus metro. And if we look at, say, the historical geographic distribution of training sites, it makes perfect sense. And currently only 8% of trainee positions are rural, and we need at least 33%, don't we, to match the population. The other interesting thing is that 2/3 of the Aboriginal and Torres Strait Islander population live in rural Australia. So in fact, the shortage of radiologists impacts doubly on that population. So if we're serious about trying to correct the health gap that exists for those people, we should be working doubly hard to correct the rural maldistribution. Now, well, is there a problem? Yeah, well, it's very well documented. Australian Institute of Health and Welfare and all sorts of people have documented the rural health gap, which is larger for the Aboriginal and Torres Strait Islander and Maori health gap. And the main cause of that is the problem of access, because of the shortage of doctors. And is there a problem? Well, yes, there is. The Australian Institute of Health and Welfare and others are very well documented. There's a large health gap of rural Australians and New Zealanders, and that's doubly worse for remote people and the Maori, Aboriginal and Torres Strait Islanders. And the major cause of that health gap is the problem of access to care. And clearly, if there isn't an adequate workforce, well, that creates a problem with access. In Australia, the Medicare utilisation rate of rural Australia is 1/2 of that of metropolitan Australia. And so, you know, if there aren't doctors there, they have to travel. And then, of course, then they get separated from support. There's time off work, there's the cost of travel and all these other sorts of things. So it is a huge problem. So we need to fix it. And the evidence shows to fix it, we need to train rurally. And that's why tomorrow morning's session is so important, because together working with others who have successfully recruited radiologists by training them in the end-to-end training, the rural radiology training program, or regional rural radiology training program. They have got people to choose and work rurally, but as I say, we need to go from 8% to 33%, and that's a big jump. And there are barriers, and so we're going to be discussing what are those barriers and how can we overcome them so we can get this, as I say, the larger pipeline. And the pipeline extends from high school. So what we want is, we want high school kids to aspire to become doctors or healthcare workers. And that includes ATSI kids and Maori kids. And but then we need rural radiology. We need rural medical schools. So we need medical schools close to where they are. One, because we know that there's an issue with respect to education engagement, just like there is with health engagement. And the closer the schools are to where they live and where their communities and where their families are, the more likely they are to attend those schools. And then they don't get socialised to become metro. If they go off to get a scholarship, say, to go off to Sydney University to do medicine, well, either they'll bomb out because it just culturally is such a huge jump for them that it's impossible to sustain. Or if they're successful, almost certainly they'll end up staying metro, and they'll choose a life partner that's metro and everything. So that's why I've worked so hard to help create all these new rural medical schools west of the Great Dividing Range. So you might have heard the Murray-Darling network of medical schools, and you could say that's probably one of the reasons I got the AM, because of the work I did with that, working with the Nationals. And so that's why I've become an advocate for more rurally based education and training. And it's not just radiology, it's not just medicine, it's nursing, it's not just healthcare, it's engineers, all sorts of things. And so I think it should be a really interesting session.
Are you seeing results already that you can actually produce as evidence that will work, that will fill that gap? And are you looking at other professions for what they've done that's proved effective?
Yeah, well, I mean, as I say, there's lots of really good observational evidence from around the world, and particularly well validated in Australia and Canada. And Canada's important because it's got the same geographic and demographic challenges as Australia. And there's no doubt that recently trained doctors, medical graduates, will choose to live and work rurally if trained rurally. Now, of course, we haven't actually proven that yet for radiologists, but at tomorrow morning's session, there will be Dr Rick Usher. Now, Rick is a radiologist, lives and works in Ballarat, Victoria. He has trainees with the RRTP, and he has successfully recruited some of those trainees. So these are local kids, do medicine, do radiology, to spend most of their time training in radiology in Ballarat, spend a bit of time in Melbourne, whatever, and then come back and want to live and work in regional Victoria. And at the same time, one of the other speakers will be Scott Robson, who is one of those graduates. So he's a new fellow of the college who was trained by Rick in the RRTP. So to my mind, they're the classic example of someone who's used the RRTP to create end-to-end radiology training and has a fellow come from that who then joins him in regional Victoria, and then the radiologist who went through that training. So I think they're important that we have them tomorrow. Say, well, here's an example. Okay, it can be done, and let's learn from their experiences.
And who are you talking to? Who can actually deliver on this for you? Is it governments? Is it the profession itself? Is it colleges? Where does this have to come from?
Yeah, good question. Listen, the framework for who's accountable, and this comes back to accountability. Who's accountable for this maldistribution of doctors and healthcare workers in Australia? Okay, well, based on a 2005 report, that was the sort of Consumer and Competition Commission. They were trying to get stuck into the College of Surgeons because it's a closed shop and blah, blah, blah. Anyway, they finally sort of created this report or review that said that it's actually up to the states and territory governments to provide the optimum workforce. But as we know, we can't rely on them. We could wait forever and it'll never happen. But as we're a profession, radiologists, doctors, we're a professional class. Society has this contract that affords us these monopoly rights and this status, and we should therefore be working in society's interest to provide radiologists for all Australians, not just metropolitan Australians. And so it is up to the colleges, it is up to the profession, but it's also up to the universities to make sure they produce graduates that want to stay rural, as well as the governments. And so I will be touching on that during my talk. So we're talking to everyone, but at this meeting, obviously, we're primarily talking to my profession and my college to say, okay, guys, we've got to lift our game.
And just to go the full circle here, in your observation of what that will mean in rural and regional areas to be able to have access to radiologists in the same way that metro people do. And we were just at a session on stroke where they talked about time is brain. What is the impact for rural and regional? Can you talk about it in terms of particular patients or what you've seen over the years in terms of that inequity?
Oh, well, stroke care is a classic example, yes. It's a huge problem. If you have a stroke in Wagga, your outcome is no way could compare to having a stroke in a metro centre where you're close to an R&R facility, where someone, if need be, if looks like you've got a small embolus in your MCA and they can fish it out and give you a little bit of blood thinner and so on, and you've got that sort of that brain at risk that recovers. Hugely different outcome. And so that's one example, yes, but there's all sorts of examples. I mean, the shortage of radiologists and sonographers means that some country women and obstetricians might have to travel 400 kilometres just to get an obstetric ultrasound, let alone travel even further to find a hospital that will deliver their baby. That's why they deliver on the side of the road. So countless examples of where the shortage of rural doctors and health workers impacts not only on outcomes, but as I say, access is also, you've got to consider, well, it's time off work. If you have to drive 400 kilometres just to have an ultrasound, and that's time off work or time away from the family, you're a young mother, you've got kids to look after, who's going to drop them off at school, pick them up from school, blah, 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 or you're working, you're helping your husband in a family business, a farm, all those things. You're away from your support when you do have cancer. You might be hundreds of kilometres away from your support. And when you're being treated for cancer, that's important. It's shown to affect outcomes.